going to talk about PPE in the post-COVID world. Is universal masking the new standard? And I have no relevant financial disclosures, but I also want to say that the title of this talk was chosen prior to the Delta surge in the US. So we're still masking now, but I want to talk about the evidence for masking and then fundamentally if we're going to be masking in the future. So I'm going to talk about universal masking in healthcare with COVID, universal masking for the public, mainly the observational studies, but one RCT in terms of universal masking, a hypothesis that we have of masking in viral inoculum, what type of masks increase protection, and then should we universally mask in healthcare settings after the Delta surge abates? So, we did not universally mask in healthcare settings before the COVID-19 pandemic. There was certainly masking in selected professions, but universal masking with patient contact was not a norm in the United States. And after this New Yorker article by Atul Gawanda, where he pointed out that in Singapore and Hong Kong, universal masking had been employed by healthcare workers to prevent healthcare workers from being infected, most healthcare settings actually put universal masking in place for COVID at the end of March 2020. And what this did, and this is a paper from July 2020 in JAMA from the Harvard healthcare system, is that you could see the pink before, which was showing healthcare workers getting SARS-CoV-2 infection that was rising. And then after the institution of universal masking in the end of March, there was a period of stability and then infections decreased. So this certainly was associated with protection in the healthcare worker setting. And really the masks that we use in the healthcare worker setting, at least for routine contact, not for contact with aerosol generating procedures or with known COVID positive patients where there is the N95 masks or the respirators. This is what we use for routine settings is a polypropylene mask, this standard issue surgical mask. And the polypropylene mask actually is negatively charged. So it repels the negatively charged viruses. So there is not just a physical barrier, but there is actually electrostatic barrier to viral repulsion from this material. And then the moisture, it also repels water, which moisture helps the virus survive. So we wrote a paper from our group about universal masking of the public in late March, early April, and also many, including us, had discussed that asymptomatic transmission was occurring with COVID. And so because of that, universal masking would be indicated. And really by April 3rd, the CDC had put into play recommendations for face coverings for the public due to the frequency of asymptomatic transmission. And it was a very deliberate message that they used, that they actually said this was there to protect others. But in the setting of sort of mixed messaging in our country, really and the increasing evidence that a mask would protect you as an individual, by November 9th, the CDC had updated their guidelines to say, actually a mask protects you and others. And though it is a very politicized thing in our country, really, there have been at least good epidemiologic and observational studies that show the benefit of masking for COVID transmission, and now one cluster randomized RCT. These are the number of epidemiologic studies that look at the effects on the public of universal masking. And for example, hair salons in Missouri or Boston healthcare setting that I told you about, or large population-based studies comparing states with mask mandates and those without. And also in Germany, and certainly if adherence to masking is measured, the effect is even higher. And that's that last study at the bottom. But really, in terms of an RCT, the only RCT that had been formed in May of 2020 was a Denmark study, and this was an individual level RCT. And the individual level RCT really was done at a time that universal masking was not prevalent in the setting. And so giving individuals masks and having them wear outside the home really wasn't the norm. And so there was lower adherence to wearing of that mask. And so we wrote our editorial along with others to that particular paper saying, we really need a cluster randomized trial where a village or a setting or a community is randomized to mask wearing versus not, so that becomes the norm there in a cluster randomized trial. And that was performed on September 1st. This is just a preprint, but essentially this was performed in Bangladesh, looking at villages that were randomized to masks versus not, and also looked at surgical masks versus cloth masks. And though the effect was small in a cluster randomized trial, it was statistically significant that surgical masks did reduce symptomatic infection. And essentially that was mostly over the age of 50, which is the group that is more likely to get symptomatic infection. So this is the cluster randomized trial that we have. So what about this hypothesis of masking and the viral inoculum? Well, it turns out that COVID is so unusual because so many of our infections are asymptomatic. And there are multiple reasons for that, including the host, including the development of a T-cell response. It's about 40% of infections are asymptomatic. And we also, of course, diagnose asymptomatic infections to try to prevent transmission, but really 40% is generally the number. But one other factor that could be was the factor of NPIs, because masks do they reduce the viral inoculum to which the wearer is exposed? Well, all of them to some level block virus. N95, of course, are the most blocking of all virus. 90 to 95% of viral particles are truly filtered out. And then surgical masks, depending on how they're worn and depending how tight they are, can go up to 75%. And then cloth masks, if they're loose, are very little effectiveness, 10%. And if they're worn well and tighter and more fit and filtered, then they can go up to the 50% range. And so is there evidence that reducing the viral inoculum, or the amount of virus that you're exposed to, reduces the severity of disease? Well, this has always been a longstanding hypothesis in viral pathology and in pathogen pathology, that the reduced getting less of a virus in or inoculum in of any pathogen will lead to less severity of disease. This is a model in mice that looked at the LD50 of a virus, or the lethal dose of a lethal dose of a virus, which is the viral dose at which 50% of animals will die. And we have seen this in a ferret model in a ferret model, but also a hamster model, that giving higher amounts of SARS-CoV-2 made the animals more sick, or led to more severe disease on a CT. And then just a paper from the other day that actually didn't get to make it into these slides shows us that a monkey model giving higher and higher amounts of challenge virus, so this would be as close to humans as we could get, led the animals of SARS-CoV-2, led the animals to become more sick. So I think we have very good animal evidence now that the viral inoculum leads to severity of disease. This is a study in hamsters that looked at basically masking hamsters, not little tiny masks like here, but they essentially simulated masking in the cages of the hamsters. And those who were given, who were masked essentially, were less likely not only to get SARS-CoV-2, but also less likely to get severe disease. They had more mild disease if they were simulated to be masked. So in terms of human experiments with SARS-CoV-2 to show that the viral inoculum has led to more severe disease, we obviously can't do that with COVID, but with viruses that have less disease severity, that has been done. So for example, giving influenza at higher doses leads to higher severity of disease in humans. This was in a challenge experiment to develop a vaccine. And then that has been done with multiple viruses, for example, rotavirus studies, rhinovirus studies, RSV studies, that giving higher levels of virus is associated with more severe disease. So if masks reduce the inoculum of infection, then it may be associated with less severe disease. Interestingly, we saw this pattern with the 1918 influenza pandemic, that what you usually see with the second wave of the virus, as you can see on the right-hand side, is lower severity of infection as immunity develops. But there was actually a higher severity of infection in the second wave of influenza, likely because of more crowding, World War I was happening, a higher dose that people were exposed to. And this actually is reminiscent of our first waves of SARS-CoV-2, where there was not NPIs in place, where there was, unfortunately, more exposure to higher dose, greater deaths among healthcare workers early, Italy and New York City, probably a lot of exposure to a higher inoculum, and household contexts are more likely to have more severe disease. This is a study from Switzerland early in the pandemic that showed that Swiss soldiers, when it was really two cohorts, and one cohort had usual procedures and the other cohort had social distancing or masks. And in the latter cohort, there was 0% illness, even though there was seroconversion, compared to 30% illness without any of these NPIs employed. And there is another theory that was propounded by NIH investigators about why masks could reduce the severity of infection, which is the humidity that's caused behind the mask actually is really difficult for the virus to survive in, and they increase the humidity in the air that the mask wearer breathes in, which inhibits it from going into the lungs. So we're not sure why, but this seems to be an association. Okay, so what type of masks increase protection? Well, really the best experiments here are the physical science experiments, which look at mannequins and then look at essentially bombarding them with particles that simulate aerosols and droplets that are the size of SARS-CoV-2. And of course, N95s are the best masks, but there's also KN95s. And then there's also a number of different options that really simulate almost 95% protection or blocking. This is a series of physical science experiments that were done by Lindsay Marr and looked at really either the combination of a surgical mask plus a cloth mask, which is really has two layers of blockage. One is physical and one is the polypropylene electrostatic repulsion. One idea is to put a filter inside two cloth masks or two layers of cloth. And there are many filtered cloths of available for these type of masks. And even a surgical mask, again, likely because of the polypropylene material, has more ability to repel virus than cloth. But if there's cloth, it should be a tightly woven fabric. And the CDC did a series of similar experiments and published this on February 9th that showed that double mask or taking a surgical mask and just making it more fit and filtered, tucking it in on the sides and doubling the loop so that it's more fit to the face, actually simulate an N95 in terms of layers of protection, or putting in a filter. So if SARS-CoV-2, and this has been a common question, is a mixture of droplets and aerosols, can surgical masks partially block aerosols? And tuberculosis as the most classic aerosol spread pathogen, this is an experiment that shows us that surgical face masks worn by patients with multi-drug resistant tuberculosis does actually block transmission. So this was an experiment where MDR TB patients were in a room and the air was piped into a room with guinea pigs, and TB patients wore alternatively either surgical masks or nothing. And there was a 56% reduction to infections to the guinea pigs when surgical masks were worn. So there is some filtration efficiency for aerosols. And so this leads to the final question in the title of the talk: should we universally mask in healthcare settings after the Delta surge abates? Well, it's important to say that there have been a number of studies that shows that universal masking actually does reduce the quality of the patient-doctor relationship. This was a 2013 study. It was a randomized trial that looked at face masks worn by family medicine doctors, and half wore face masks, half didn't. And then there was a randomized study asking patients how they felt. And really, face masks significantly impeded perceived empathy and relationships between doctors and primary care patients. There have been a number of studies, even in the setting of COVID-19, where there's an attempt to use nonverbal cues, and those really are impeded by masks. And then there was a study in the JAMA surgical literature that standard covered masks were perceived by patients as reducing empathy, and looking at the effect that it was improved to even have clear masks. So all of that together, the question is, do you think we'll be universally masking in healthcare settings? Well, the CDC doesn't actually think that's going to happen. And I think it's important to remember that even in the setting of public universal masking, that the CDC on July 30th, when they put back masks for the vaccinated, really had criteria that they had into play that looked at transmission levels in the area and then determined when mask mandates could be lifted. And even though their transmission levels are pretty stringent and more consistent with parameters that made sense prior to vaccination, low and moderate transmission, no need for masking in that setting, and they recommend masking in substantial and high transmission. And so what the CDC interim infection prevention and control guidelines on September 10th said is that unmasking as well in healthcare settings could be done in areas of low and moderate transmission, where the community has low and moderate transmission, at least in settings where healthcare workers are gathered together and fully vaccinated. So staff rooms, conference rooms, etc. And they plan to update these guidelines as the COVID-19 pandemic evolves. So the key points for the new guidelines for healthcare workers is source control, means an N95 or equivalent or well-fitting face mask in routine healthcare settings. And certainly if the patient is positive or you're doing an aerosol generating procedure, this does require an N95. And then in recognition of the long toll of the pandemic in regions with low or moderate community transmission, fully vaccinated healthcare workers around each other don't need to mask, at least in places where they're fully vaccinated together, continue to mask around immunocompromised patients or around patients, and these guidance will continue to evolve. So I'll end with this cute picture from the 1918 pandemic with the whole family being masked, including the little cat. Thank you very much.